Alright, hi guys. Hopefully this recording will actually...
The broadcast is now starting. All attendees are in listen-only mode.
I think you heard that, so hopefully that means this recording is working. I might chop it up into a couple units just to make sure that it is recording and that I don't have to re-record the entire thing. So I'll let you know how many parts there are to this presentation. So if you have listened to the other version, I will probably repeat myself, so I would recommend maybe just watching this one, provided the video works. So a bit of a disclaimer as we head into Unit 7, ECG Interpretation. It's a fairly complicated topic, so if you're not understanding it the first time, don't stress too much. I think the beauty of this being a recorded lecture is that you can actually pause it, rewind, and re-listen to and review the material over and over and over again until you feel like you have a good grasp on the material. So I would highly recommend that as you go through this presentation, if at any point you feel like you need to go back and listen to something again or try it out or practice it, absolutely do that. Keep in mind this lecture will probably take an hour and a half-ish, and if we were in class, we'd be stopping a lot to talk about questions and practice and things that you may not have understood the first time around. So definitely take the time to go back and do that. And if you do have any questions, post them on D2L. I'm more than happy to answer them there. So as we get into the lecture, we'll be talking about our basic ECG interpretation. We'll talk about the cardiac conduction system, how that works, how that results in mechanical output. Then we'll talk about ECGs, what they are, how you get them, why we take them, and when we take them. And then we'll get into our basic rhythms, our benign arrhythmias, some life-threatening arrhythmias, and then finally lethal arrhythmias. So if we talk about the cardiac conduction system, the cardiac conduction system is very unique. Why is that doing that? Okay. Sorry. The cardiac conduction system is very unique because it's got certain criteria, certain characteristics. So if we talk about automaticity, so automaticity is the ability of the cells within the cardiac system, so heart cells, to generate electrical impulses on their own. So the cells themselves can generate these electrical impulses, and that makes them pacemaker cells. And so when I talk about an electrical impulse, I'm talking about the ability to create electricity within a cell. And there are only two cells in the body that can do this, and those are neurons in the brain and cardiac cells. So keep that in mind. So when you talked about, you probably talked about automaticity in the brain in terms of your anatomy course. So the same way that impulses are traveled that way in the brain, they do the same thing in the cardiac system. So those cells can pass on electrical signals from cell to cell in the cardiac system. The way that they do this is rhythmically. So again, the cardiac conduction system has rhythmicity, which means that those impulses are created or generated rhythmically. So if you feel your heartbeat, or if you feel the heartbeat of a healthy person, you'll feel the lub-dub, 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 lub-dub. You'll feel that that's very rhythmic. When we get into something like ventricular fibrillation, you'll notice that that is not rhythmic. There's sort of a spastic contraction, spastic electrical impulses within the heart, and those are not conducive to perfusion. So rhythmicity is very important when it comes to perfusion. If we look at conductivity, so the cardiac conduction system, as I said a little earlier, has the ability to spread those electrical impulses from cell to cell. So that's what the conductivity refers to. So spreading that impulse from one cell to the next, to the next, to the next. And because we are moving electrical impulses, and because we want that to happen rhythmically, we have something called the refractory period, and that's a period where the heart cannot respond to another electrical impulse because it needs time to repolarize, or in other words, it needs time to rest. So imagine if you just ran a marathon. So you just ran 42 kilometers. Do you think you'd be able to run another 42 back-to-back? Probably not. That's not what you were designed to do. You need a certain amount of rest time. You need a certain time of regeneration time. And that's kind of what the refractory period of the heart is. It physically cannot respond to another impulse until it relaxes, until it rests. And relaxation and resting in terms of the heart means that certain ions are set back to their normal range. And then finally, we'll talk about Starling's law. So Starling's law states that the greater the myocardium is stretched, so think about the heart as a muscle, the greater that it is stretched, the greater force with which it will contract. So imagine a balloon. So if you have a balloon that you are blowing up to its capacity, to its full capacity, so you're blowing it up really, really big to the point that it almost explodes, it almost bursts. If you release that balloon, it's going to contract rather quickly, and all of the air within that balloon is going to deflate very quickly. Now think of that same balloon that you've blown up to its maximum capacity 100 times. Do you think that by the end of that 100th time, it's going to deflate as quickly? No, probably not, because the elasticity in that balloon will not be as strong as it once was. So the heart is the same. So you can expand and contract the heart, and it will do so efficiently to a certain degree or to a certain extent. If you abuse that heart, or if the muscle within that heart becomes weak or overstretched or enlarged, it won't be able to contract with as much force as it once did. So again, the greater the myocardium is stretched to a certain extent, the greater force with which it will contract. So this is just a diagram of that refractory period. So within those two dotted lines is a period in which the heart cannot contract, and we'll talk about what this ECG looks like in a little bit. This is a time in which the heart cannot respond to another electrical impulse. So we'll talk about that a little bit later. So here's sort of a diagram of the cardiac conduction system for those of you who like sort of visual learning. So if you take the cardiac conduction system, you start up here in the SA node, the sinoatrial node. So this yellow dot signifies a cluster of those pacemaker cells. So these are cells that can create their own electrical impulse found in the upper portion of the right atrium called the sinoatrial node. So these cells will create an impulse, create a current, and pass that current down here to the AV node. So the AV node is another cluster of these cells that are that have automaticity, so they can create their own electrical impulse. So again, the initial electrical impulse is created in the SA node, the sinoatrial node. That electrical impulse is passed down to the AV node, which is the atrioventricular node, found a little bit lower in the right atrium. And that electrical impulse will pass to the septum, so in between the left and right ventricles, to a region called the bundle of His. Now this diagram calls it the His bundle. Most of us would refer to it as the bundle of His, but either is fine. So that electrical impulse sits here in the bundle of His, and then is directed down two pathways, each of these pathways called a bundle branch. So we've got the left bundle branch and the right bundle branch. So again, that current is passed from the SA node to the AV node into the bundle of His, which it then separates into two bundle branches, the left and right bundle branches. And that travels all the way around the myocardium, so all the way around the ventricles. And each of these pathways will then sort of spread out, branch out into these fibers called Purkinje fibers. And these fibers will actually innervate the muscle. And innervate simply means to sort of stick into. So it's going to reach its fingers into the myocardium, into the ventricular muscle, to make sure that that ventricle contracts in its entirety and that it does so forcefully. So the conduction system here starts up in the SA node, down to the AV node, down to the bundle of His, separates into two bundle branches, surrounds the ventricles, because the ventricles are quite large. They have a lot of muscle that surrounds them, and they need to forcefully contract because we're pushing blood all the way around the body and to the lungs. So these Purkinje fibers innervate that muscle to ensure that the contraction is in sort of one beat, and that's very strong, and it's strong enough to move blood to the entire body. So here's the exact same thing, a depiction sort of in a flow chart form for those of you who like to learn this way. So again, that initial impulse comes from the SA node. And some added information here. So that primary pacemaker. So the SA node is considered a primary pacemaker because it's the first part in the heart that will generate the impulse. It generates impulses between 60 and 100 beats per minute. 60 and 100 impulses per minute. Each of those impulses in a healthy heart will cause the heart to contract, and that's what results in the mechanical output of blood. So the SA node will create the electrical impulse, will force or cause the heart to contract, and each of those contractions is measured in beats per minute. So again, the primary pacemaker, which is the SA node, will cause approximately 60 to 100 beats per minute in a healthy heart because it's firing its impulses 60 to 100 impulses per minute. So those impulses are passed down to the AV node and then into the bundle of His. So interestingly, your body has built in several backup plans. So if for whatever reason the SA node isn't working, the bundle of His is going to pick up a little bit of that slack. So the bundle of His has an intrinsic pacemaker and can create impulses at a rate of 40 to 60 beats per minute. So again, the impulses will fire 40 to 60 per minute coming out of the bundle of His, which will cause the heart to contract between 40 and 60 beats per minute. So that impulse will then head down the left and right bundle branches and into the Purkinje fibers. And again, interestingly enough, your heart's built in a plan C. So if for whatever reason the heart is damaged, the SA node is not working, the bundle of His is not working, the Purkinje fibers will initiate impulses at a rate of 20 to 40 per minute. Now, if you think of a patient who's got a heart rate between 20 and 40, do you think that patient has enough perfusion to sustain life for very long? Probably not. So this patient is probably not going to survive very long. This is not enough to sustain life. This is enough to get medical attention rather quickly, and hopefully we can reverse the causes. However, this is not something that's going to sustain life. Okay, so the plan Bs and Cs are not life-sustaining. They are sort of plan Bs and Cs to get some medical attention. So we need to sort of look at ECGs. So this is the beginning of the ECG what part of the presentation. So we've talked about the cardiac conduction system, and so we know that cardiac conduction is electricity. So there's electricity passing through the heart, and that electricity is converted to a mechanical output. So the mechanical output is the heart contracting, forcing blood through the body's circulation system. So the mechanical output is feeling a pulse. The electrical component is what can be measured on ECG paper. And we'll talk about how that electrical component signifies or identifies some sort of mechanical component. So again, the electrical component is the impulse. The mechanical component is the physical contraction and then feeling of the pulse. The feeling of your pulse is your mechanical output. So the way that we measure these electrical impulses is by recording an ECG, so an electrocardiogram. So gram, as you remember from your medical terminology, is simply a recording of. So we're recording an electrical impulse here. So I would encourage you to head down to your lab at some point and get some ECG paper from a defibrillator or from one of the medics in the lab, and look really closely at your ECG paper. So you'll notice it's white paper with a bunch of pink lines on it, and you'll notice that there are big boxes and little boxes. So within the big boxes are usually 25 little boxes. And so if we look at one of the big boxes here, delineated by the dark lines, and then magnify that big box, you'll notice that there are 25 little boxes within that one big box. And these boxes are important because they represent duration in time. So if you look at one of these big boxes here, that represents 0.2 seconds in time. And then if you magnify that big box into the little boxes, one little box horizontally represents 0.04 seconds in time. And that's really important when we start to interpret our ECGs. So again, one big box horizontally represents 0.2 seconds, and one little box horizontally represents 0.04 seconds. On the vertical axis, we have voltage, so the amount of energy. So here's a depiction of an actual ECG on that ECG paper. So again, let's just do a quick little review here. You'll notice these dark lines on the ECG paper. These represent one big box, which is actually identified over here as 0.2 seconds. So one big box horizontally represents 0.2 seconds. Within the big box are all of these little boxes, and horizontally each little box represents 0.04 seconds. And I'll show you how that becomes important soon. So if we look at the black line on this ECG paper, so the black line is our ECG tracing. And so this ECG converts what's happening in the heart electrically into something that we can actually read, into an electrocardiogram, so into a recording, something we can see, something we can read. And so that black line starts over here on the left, and anytime you see a flat line like this, in the presence of a complex that looks like this is referred to as an isoelectric line. So the isoelectric line is kind of like neutral. This is where we want to head back after a large complex. So we start our ECG here at the isoelectric line, and you'll notice your first positive deflection, positive meaning upwards and negative meaning downward. So the first positive deflection here is labeled P. So our first positive deflection is our P wave. And our P wave represents the atria contracting. So if the atria is contracting, we know that they've forced blood into the ventricles. So after this first P wave, we return to the isoelectric line, and we head into our first negative deflection. So our first negative deflection is called our Q wave, followed by a significant positive deflection, named our R wave, followed by a second negative deflection, named the S wave. And so normally, we combine these three into one thing called our QRS complex. So our Q wave, our R wave, and our S wave are combined and referred to as the QRS complex. So after our QRS complex, we return to our isoelectric line. And the point at which we return to that isoelectric line, right here that I'm circling, is called the J point. So again, we return to our isoelectric line, and then we see yet another positive deflection. This one's called our T wave. So our T wave looks very similar to our P wave, however it's a little larger. Okay, so let's head back to the beginning here. So first positive deflection is our P wave. We head back to the isoelectric line. The P wave represents the atria contracting. Then we have our large QRS complex. And our QRS complex represents the ventricles contracting. Head back to the isoelectric line. And then our T wave represents the ventricles repolarizing, which is sort of their relaxing phase. So a quick summary again, our P wave represents our atrial depolarization or our atrial contraction. Our QRS complex represents our ventricular depolarization. The Q wave within the QRS complex is the first negative deflection, the R wave the first positive deflection, and the S wave the second negative deflection. So again, the QRS waves together are called our QRS complex. And the J point is the point where the QRS complex returns back to the isoelectric line. The T wave, as I said, is representative of your ventricular repolarization, so that's sort of the resting phase, heading back to neutral. And the isoelectric line, again, is neutral, and that's considered our polarization phase. So that's our polarized phase. That's our readiness to contract, our readiness to do something. And so here's where the time becomes important. Our PR interval, which I'll go back and show you in 1 second, should be less than 0.2 seconds. And our QRS should be less than 0.12 seconds. So let's go back here. So our PR interval is measured from the beginning of the P wave, so what, that first positive deflection, all the way over to the beginning of the QRS complex, or the first negative deflection. So this is our PR interval, and that in a normal heart should be less than 0.2 seconds. So it should be less than one big box in duration. So our PR interval from the beginning of the P wave to the beginning of the Q wave should be less than 0.2 seconds, which is equivalent to one big box. So less than one big box is what we're looking for in a normal healthy heart. The other measurement we want to see is from the beginning of the QRS complex to the end of the QRS complex. So the first negative deflection and then to our J point. We want this to be less than 0.12 seconds or less than 3 little boxes. So that's our goal here. In a healthy heart, the QRS complex will be less than 0.12 seconds, which is less than 3 small boxes. So I'd recommend right now, if you're at all lost, or if you need clarification, or if you just need to go over that a couple more times, draw it out, write it out, say it out loud, pause the lecture right now, go back, and have a closer look. Re-listen to it over and over and over again if you need to understand this part, because if you're not quite there yet, the rest of the lecture will be very difficult. So again, I'd recommend you stop here, rewind, listen to this over and over again until you feel like you've got a good grasp on it, and then move on. So if we look at identifying ECGs, so we're going to get into ECG interpretation. So ECG interpretation is looking at an ECG and determining what it is. What does it represent? What's it called? And what does it mean for the patient? So there's a step-by-step process to ECG interpretation. The first step is to determine the heart rate and whether it's regular or irregular. So there's a couple ways to determine heart rate. The first way is to print off a 6-second strip and then count the number of QRS complexes within that 6-second strip.